It's very well established that sequencing should be THP in the frontline setting for HER2-positive metastatic breast cancer, and in the second line, TDM1. And this sequence is established based on well-developed, well-run phase 3 randomized trials that showed not only a significant improved PFS, but also overall survival compared to standard therapy at the time. After that, it really is sort of a mishmash of choices. And so, of course, we take into consideration the hormone receptor status of the tumor and the patient's performance status and comorbidities when making a treatment recommendation in the third line setting and beyond. I personally really like trastuzumab and vinorelbine, a very old-fashioned regimen that has got great efficacy. I've had patients take this regimen for years without having disease progression or needing to hold therapy for toxicity. Tends to be very well tolerated. Capecitabine-based regimens as well in combination with trastuzumab or lapatinib are certainly appropriate and are easier for patients due to the toxicity profile and lack of hair loss. And then any chemotherapy as a single agent that's standardly used for breast cancer can be paired with a HER2-targeted agent. Joyce O'Shaughnessy's data looking at trastuzumab and lapatinib together is compelling in the later line setting. And we certainly have data to support pairing of endocrine therapy with HER2-targeted therapies as well in the later line setting. So I think up through most of 2019, that has been our standard regimen available. Now we have new data coming out that I think is going to define beyond the second line setting even further for us into 2020.
In patients with first-line metastatic disease, we typically use a Cleopatra-like regimen, which means that we're going to be using early on trastuzumab and pertuzumab with a taxane. And among those patients who ultimately develop a recurrence of their disease or progression of their disease, because we're not curing those patients, at the time that they do develop progression of disease, the question then becomes, what do we do with them? And in that situation, if they haven't received TDM1 before, that's generally viewed as the standard second-line therapy. There are patients, as noted earlier, that if they had received preoperative chemotherapy in an earlier stage setting and had residual disease, it's conceivable that at that point they've already had pertuzumab, trastuzumab, and then they're going to get TDM1. And then at some later date, if they develop metastatic disease, the question then becomes, how do we go about treating them? So if the distance between the prior therapy and the development of metastatic disease is fairly long, I think the slate is generally fairly clear, and you could consider any of those other agents again. But typically, if somebody has already been through pertuzumab and trastuzumab, as well as TDM1, it's very much the Wild West in the sense that there isn't a clear recommendation right now, we'll talk about that I'm sure, about what the next line of therapy would be. And as a result, if you look at guidelines, what you see is that a number of different chemotherapy drugs could be combined with trastuzumab. And there are also older regimens that are still viable options, including lapatinib and capecitabine, or even in certain situations, lapatinib and trastuzumab. So there are many different options, and it's a choice in many ways among equals. And when talking or evaluating a given patient, deciding what their comorbidities are, what their pre-existing toxicities that continue from prior therapy, and then looking at what your options are and deciding what's best for that patient.
Clearly, the introduction of HER2-directed therapy, such as trastuzumab, pertuzumab, TDM1, have greatly improved the outcomes of patients with HER2-positive metastatic breast cancer. Right now, the standard of care for first-line patients is a taxane with trastuzumab and pertuzumab based on the Cleopatra data. That study showed substantial improvements in progression-free and overall survival with relatively modest increases in toxicity by adding pertuzumab to a chemotherapy trastuzumab regimen. So that, in my mind, is the clear standard of care for first-line patients. In the second line, similarly, the Amelia trial demonstrated the superiority of TDM1 over capecitabine lapatinib, and therefore TDM1, which is typically quite well tolerated in the metastatic setting, in my mind, is the standard of care in the second line. In the third line and later, there really is no clear standard of care. I think the take-home message in that setting is that it's important to continue the HER2-directed therapy, either trastuzumab or in certain times lapatinib, in addition to chemotherapy. In general, I don't think there's a strong preference for one chemotherapy over another, and I typically leave that up to patient preference. But drugs like capecitabine, gemcitabine, vinorelbine, and eribulin all make good partners for trastuzumab, and capecitabine lapatinib also is a option as well. You can use trastuzumab with lapatinib in select patients, and endocrine therapy plus HER2-directed therapy is also an option for those patients who are estrogen receptor positive as well as HER2 positive. But generally, we just rotate the chemotherapies and continue the HER2-directed therapy. Unfortunately, the efficacy of those regimens is relatively limited, and new therapies are definitely needed for that third and later line setting where there, again, is not a clear standard of care.